let's talk about a cardiac crisis. When a heart is in trouble, the clock starts ticking. I mean, instantly. Every single second is critical, and knowing the right drug to give at the right time, that can change everything. So today we're diving deep into the emergency drug kit to really master the pharmacology that helps us turn chaos into control. Okay, here's our game plan. We're going to start with the backstory, the chronic problem that sets the stage for a full-blown crisis. Then we'll get into the detective work, how to read the crucial clues to know what we're dealing with. After that, we'll tackle the electrical chaos that can happen and, of course, unpack the pharmacological arsenal we use to fight back. And we'll finish up with some absolutely critical details, the gotchas you need to know. You know, pretty much every cardiac emergency has a backstory. It doesn't just happen out of the blue. It usually starts quietly as a long-term problem that's been brewing inside the coronary arteries for years. Let's break down how that chronic condition can suddenly just explode into an acute, life-threatening emergency. So picture this. A patient shows up and they're having chest pain. This is the first, most fundamental question you have to answer. Is this a warning sign of a chronic underlying issue, or is this the main event? Is this a heart attack happening right now? Getting this right from the get-go is absolutely everything. And here is the core distinction you have to get straight. On one hand, you have coronary artery disease, or CAD. Think of this like pipes slowly getting clogged over many years. That's atherosclerosis, building up plaque. It's the long-term problem. On the other hand, you have acute coronary syndrome, or ACS. This is the emergency. This is when one of those plaques suddenly ruptures, a clot forms on top of it, and bam, you have a sudden blockage. The heart muscle is starved of oxygen. So CAD is the prequel. ACS is the crisis. This is such a fantastic analogy for stable angina, which is that classic warning sign of underlying CAD. The pain feels like a tight rubber band stretched across the chest. It's caused by a temporary lack of oxygen. And what makes it stable is that when you stop exerting yourself, when you rest or take a drug like nitroglycerin that opens up the arteries, the demand for oxygen goes down, the rubber band loosens, and the pain goes away. It's a huge clue that something is wrong. All right, so we've determined it's an ACS event, it's a heart attack. Now the detective work really kicks into high gear. We have to get more specific. And the patient's electrocardiogram, the ECG, is what gives us our biggest clue. It literally splits the treatment path into two totally different directions. So it all comes down to the size of the blockage. An NSTEMI, that's a non-ST elevation myocardial infarction, is a partial blockage. The ECG won't show that really dramatic ST elevation we're looking for. So how do we know for sure? We have to do a blood test for cardiac enzymes, specifically troponin. If that's elevated, we've confirmed it. But a STEMI is the big one. This is a complete blockage. It's so severe it leaves a very clear, very scary signature on the ECG called ST segment elevation. This is a 5-alarm fire requiring immediate action to open that artery back up. And this visual just shows it perfectly. On the left, that's a nice, healthy-looking ECG. See that flat line between the sharp spike and the next little hill? That's the ST segment. It's right on the baseline where it should be. Now, look to the right. Whoa. See how that same segment is jacked way up, like a giant wave? That's ST elevation. Some people call it a tombstone pattern, and honestly, that's not far off. It is the heart muscle screaming for oxygen because of a total blockage. Seeing this changes everything. So when a part of the heart muscle is being starved of oxygen, it gets electrically irritable and unstable. This is when the really dangerous stuff starts to happen. We see these life-threatening arrhythmias pop up. The heart's entire electrical system gets thrown into chaos, and this is what so often leads to cardiac arrest. Okay, the first electrical problem we can run into is the heart rate dropping way too low. We call this bradycardia. Now, a slow heart rate by itself isn't always a problem. Think of a well-conditioned athlete. But when it becomes symptomatic, that's the magic word, when the person is getting dizzy or confused, or their blood pressure is tanking because the heart's not pumping enough, then we have to intervene, and fast. And on the flip side, the heart can beat way, way too fast. That's tachycardia. According to the guidelines, once that rate starts pushing past 150 beats per minute, we get really concerned. And when it becomes unstable, meaning it's causing chest pain or signs of shock or the heart is starting to fail, it's a massive emergency. We have to slow that rate down immediately before the heart just gives out. And this, right here, this is one of the rhythms that makes every provider's own heart skip a beat. It's ventricular tachycardia, or VTach. Just look at those wide, bizarre, fast complexes. What's happening is the ventricles, the main pumping chambers, are just firing off uncontrollably. They're beating so fast they don't have time to fill with blood, which means cardiac output drops to almost zero. VTAC is incredibly unstable and can flip into ventricular fibrillation, total chaos in a heartbeat, leading to sudden death. All right, so we've diagnosed the problem, we've identified the scary rhythm on the monitor, now it's time to fight back. Let's open up that drug box and take a look at our pharmacological arsenal, the tools we use to manage the ischemia and get these deadly rhythms back under control. Okay, for chest pain, first up is nitroglycerin. You have to know this protocol cold. It's 1 tablet, sublingually, under the tongue. If the pain is still there after 5 minutes, you give a second dose. Still there after another 5 minutes, you can give a third dose. But that is it. The absolute rule is no more than 3 doses in 15 minutes. If that third dose doesn't work, this is a true medical emergency. Now, what about those electrical problems? We've got specific drugs for specific rhythms. If the heart's going too slow and the patient's symptomatic, we reach for atropine. If we need to break a stable, super fast, narrow complex rhythm, we use adenosine. That's the one that gives the heart a quick reboot. And for the really life-threatening ventricular nightmares like VTAC and VFib, we bring out the big gun, amiodarone. You've got to match the right key to the right lock. In a cardiac crisis, heart failure often comes along for the ride, and we need to get rid of excess fluid with diuretics. But here is a massive catch you have to know, especially for exams. It's all about potassium. Loop diuretics like furosemide, you probably know it as Lasix, are super powerful, but they waste potassium, putting the patient at risk for hypokalemia. On the other side, you have potassium-sparing diuretics like spironolactone, which, you guessed it, do the exact opposite. They hold on to potassium, creating a risk for hyperkalemia. Knowing this difference is absolutely vital. So the patient is stabilized, the immediate danger is over. But the work is not done. Now we shift to protecting the heart for the long term. We use a cocktail of meds. Beta blockers, the olol drugs, are fantastic. They basically tell the heart to take a deep breath and slow down, reducing its workload and its need for oxygen. ACE inhibitors, the prill drugs, are crucial for preventing the heart from changing shape in a bad way after it's been injured. And of course, good old aspirin, which keeps platelets from getting sticky and forming new, dangerous clots. Okay, now for the good stuff. These are the details that separate the novices from the experts. These are the critical little warnings, the pro tips, and the gotcha questions that always seem to show up on exams. Pay close attention here. Let's talk about atropine again. We use it for symptomatic bradycardia, right? Well, here's a crucial safety point. The minimum recommended dose is 0.5 milligrams. Why? Because if you give a smaller dose, it can have this bizarre paradoxical effect and actually make the heart rate go even slower. It's a huge safety detail you absolutely have to remember. Oh, this is a classic exam question trap. Not all beta blockers are created equal. A non-selective one, like propranolol, doesn't just block beta-1 receptors in the heart, it also blocks beta-2 receptors, which are in the lungs. And blocking those can cause the airways to constrict. So giving this drug to a patient with asthma, you could trigger a severe asthma attack. You should always question that. Here's another huge safety tip, this time for ACE inhibitors. They carry a known risk of something called first-dose hypotension, which is exactly what it sounds like, a sudden, dramatic drop in blood pressure after the very first dose. So the rule is simple and safe. Start low and go slow. You always begin with a tiny dose and titrate it up carefully to avoid that dangerous side effect. Hey, remember our diuretic slide and the whole potassium problem? Well, here's how clinicians handle it in the real world. They'll often prescribe a potassium-wasting diuretic, like furosemide, right alongside a potassium-sparing one, like spironolactone. It's brilliant, really. You get the powerful fluid-removing effect of the furosemide, while the spironolactone works to counteract the potassium loss, helping to keep the patient's levels much more stable. It's the best of both worlds. So, we've walked through this incredible arsenal of powerful, life-saving drugs. But I want to leave you with this final thought. These medications don't work in a vacuum. A patient's lifestyle choices, the very diet, smoking, and exercise habits that likely contributed to their heart disease in the first place, profoundly impact how well these medications work. So how do we bridge that gap between the miracle of emergency pharmacology and the hard work of long-term prevention? That right there is the ultimate challenge.